So hello and good evening. Welcome back to the AMSNY Diversity of Medicine webinar series. My name is Jenny Tassler. I'm the Director of Government Relations and External Affairs here at AMSNY.
Hi, everyone. My name is Nyla Lindo. I'm the Diversity, Equity, and Inclusion Programs Manager at AMSNY.
Great. Just a few housekeeping notes as we get started. We do want to maintain an open and engaging atmosphere for the session. So if you can, we encourage you to turn on your camera during the webinar. We understand you may not be able to. However, when you ask a question, we would like you to see your face if we could. If you're not speaking, you're all coming in on mute, so that'll minimize background noise. We can ask you to unmute as needed. If you have a question for our presenter, and we encourage you to ask questions, please do. Please put the question in the chat and we can come around and either ask the question for you if you can't come off mute, or if you can, we'll ask you to unmute and ask your question. So we're going to get started tonight with intros from our panelists. Tonight's topic is urology, and we are joined by 3 urologists at various points in their academic careers and their professional lives. So Dr. Gregory Joice, Dr. Gina Badalato, and Dr. Daniel Schoenfeld. So I'm going to ask each of you to give a little intro of yourselves and we'll get started. Dr. Joice.
Hello, hope everyone can hear me. My name is Greg Joice. I'm a urologist here at Columbia, assistant professor of urology. I did my medical school here at Columbia, and then I went on to train at Johns Hopkins in urology, and then I did a fellowship in UT Southwestern in Dallas. My focus right now is on reconstructive urology and benign urology, specifically on men's health, transitional urology, transgender care, and prostate cancer survivorship, amongst other things. So looking forward to a nice discussion and happy to answer any questions.
Dr. Badalato.
Hi, everyone. Thanks for joining us this evening. My name is Gina Badalato. I'm also an assistant professor of urology here at Columbia. Dr. Joice and I are colleagues, and I've spent my entire professional career here at Columbia. My practice specializes in female urology and voiding dysfunction, so that involves people with various forms of incontinence, recurrent urinary tract infections, different types of pelvic pain, workup for blood in the urine, things of that nature. I also work a lot with medical students and residents as part of my role as Director of Medical Student Education. And I'm excited to be here tonight.
And Dr. Schoenfeld.
Hey everyone, I'm Donnie Schoenfeld. I'm a 4th year urology resident here at Columbia. You don't specialize in urology until you're done with residency. I happen to be leaning towards kind of a more general urology career path. I went to medical school at the Albert Einstein College of Medicine up in the Bronx. Among the panelists here, I'm kind of the closest to where you guys are at right now. I intimately remembered what it was like being a med student just a couple of years ago. So hopefully kind of any questions from that perspective, I'm happy to answer and happy to be here. Looking forward to speaking with you guys.
Thanks so much. Nyla, do you want to get started?
Yes. So first question for everyone. Could you tell us about your path to medicine? Were you always interested in becoming a physician?
There we go. I can get started. Yeah, my pathway to medicine, I had been interested in being a doctor for quite a while. However, I wasn't 100% committed. So actually after undergrad, I went and did 2 years in consulting and management consulting out in San Francisco, which was a really good experience. I learned a lot of good skills, but that kind of solidified my desire to go back to medical school. And so I did end up going back to med school after my couple of years off. I think I learned a lot there, but really haven't looked back since. In terms of my path to urology, I fortunately got involved with some really excellent people, one of whom is on the panel, and Dr. Badalato, and the other is our current chairman, Dr. McKiernan, early on in my medical school education, and just got introduced to the field of urology. I'd always been interested in the surgical subspecialty, and just started to love the people and then really grow into the field itself. And urology is one of these fields where it's narrow compared to some general fields like internal medicine or general surgery, but there's a huge breadth of different patients, cancer cases, non-cancer cases, men, women, all types of patients that you see within urology. And that really attracted me, and really, I've been very, very happy with my decision and enjoy my job pretty much every day.
I grew up in a household. My mother is a nurse, and she was, while I was in elementary school, was working through nursing school at the same time as raising my brother and I. So we were very aware of her coursework. We went to her classes. We heard about everything she was doing at work when she came home, and it really kind of inspired me at a very young age. And so I did know I wanted to pursue a career in healthcare. I wasn't sure whether I wanted to be a doctor, nurse, what capacity, but through experiences volunteering in college, I figured out my pathway was towards medicine. And then, I applied to medical school, half thinking I would never get accepted, but I did. And as Dr. Joice was saying, I think just mentorship plays a huge role. I did not come into medical school thinking I wanted to be a urologist. It would have been the furthest thing on my checklist. But I had some of the same mentors that he did, Dr. Joice, and I think that makes all the difference. It kind of opens your eyes to the fact that, hey, this could be for me. I could see myself doing this. This person inspires me, and this work inspires me. And I think that that's a huge part of career decision making.
Hey, I'll go next. Yeah, I didn't really grow up with any doctors in my immediate family. So for me, kind of growing up, there was always this kind of like idealized view of like the amazing doctors, But that being said, actually, I in college majored in political science. I didn't enter college knowing that I wanted to go into medicine at all. I thought maybe I wanted to do some like health policy related stuff. When I was in college, there was like a lot of the Affordable Care Act stuff kind of going on. And I was interested in it. And then I think kind of just through some volunteer work, I realized that I really wanted more of kind of the one-on-one personal human interaction. And I felt like medicine kind of made sense in that regard. In terms of kind of transitioning from medicine to urology, I kind of went through medical school and just like loved all my rotations, except for one, but I'm not going to say which one. But for the most part, I loved pretty much all my rotations in med school. And so choosing a field was actually really challenging for me. I realized I really liked being in the operating room and kind of using my hands technically. I thought was very satisfying. And then part of it was kind of me trying to gravitate towards people who I felt like I could relate to, who I felt were like kind and very decent, didn't take themselves so seriously. And in that sense, I really just liked urologists in general. And then as a field for me, I was kind of really attracted to the notion of helping patients deal with kind of very stigmatizing kind of personal areas in their life, like sexual dysfunction, incontinence. I think all those things are really important for kind of quality of life, and people are embarrassed to talk about them, but they're so important. And I felt like it was really meaningful work to kind of work with patients on those things.
Great, thank you for sharing. So as we learned a little bit at the beginning of your introductions, within urology, there are many subspecialties. So to Dr. Joice and Dr. Badalato, how did you become interested in your subspecialties? And was there a case or topic that you remember that drove you to want to study the subspecialty some more? And then to Dr. Schoenfeld, I know you said you're going the more general route, just kind of why? That came out wrong, but what made you choose going this route instead?
It might be helpful to set the stage and talk about like the 6 main disciplines in urology first so that everybody knows what we're talking about when we say what a urologist does. So urologists treat different problems involving the urinary tract as well as the genital area. And there are 6 main areas of urology, one of which is voiding dysfunction, which I mentioned. This could be any trouble with urination, spans the gamut of different types of incontinence to BPH or benign prostatic hypertrophy or trouble urinating due to prostatic enlargement. And so this involves all different types of people, not just people with male internal and external genitalia. A lot of times that's a misconception that urologists only take care of people of the male sex. Another area is stone disease, so treating kidney stones, removing kidney stones, and figuring out why people form kidney stones. A third area is oncology, so this involves many types of cancers that involve the urinary tract. The 3 most common are bladder cancers, kidney cancers, and prostate cancer. Pediatric urology, so this involves different problems of hydronephrosis or recurrent urinary tract infections in children, or different types of bladder disorders in children, and also different issues that may arise with the genitalia in children, such as evaluating them for undescended testicles, hernias, and a whole host of other conditions. Reconstructive urology, which is one of the fields that Dr. Joice specializes in. This is complex surgery, a lot of times using different techniques that you might use in plastic surgery to reconstitute parts of the urinary tract, or do complex genital surgery such as gender-affirming surgery. And then the last area is sexual medicine and infertility. So this involves different types of sexual conditions that may affect people, such as low testosterone, erectile dysfunction, issues involving perimenopausal symptoms, low libido, things of that nature. And also the infertility component are people with male factor infertility. So either people that need an evaluation for infertility or know the source of their infertility and want some help with different assisted reproductive techniques. So those are the 6 areas of urology. So now maybe Dr. Joice, you could talk a little bit about your specific areas and why you chose those areas.
Yeah, for sure. So I went into residency really high on urologic oncology. It's what I had done research in as a medical student, and I chose my residency somewhat on the thought that I would be doing that as my career. And it's a 5 or 6 year residency, so you have some time to decide. And I got there, and while I really do like urologic oncology, I just found, for me, the skill set and the uniqueness and somewhat of the, how do I say it, creativity that's involved in reconstruction really drew my eye. I also felt like I could still be involved in cancer, patients. One of the favorite aspects of my practice, I see a lot of different patients, but is in cancer survivorship. And so that's the process of taking care of patients during and after cancer treatment. And so a patient may have prostate cancer and they'll get treated for that with either surgery or radiation. And even if they're cured of cancer, they may have several quality of life implications, including erectile dysfunction and urinary incontinence. And they kind of come to see me to, help improve on those things or talk to them. And so that's a really nice aspect of my practice. And then, that last part that I mentioned, I really enjoyed the quality of life aspect for care and surgery. It's a little bit of a different conversation than if someone's coming in with you with a new diagnosis of cancer. That's an important conversation, and there's excellent people, that we have to have that conversation. But it's a different type of conversation when someone has a real problem that may be difficult for them to talk about: ED, incontinence, difficulty with urination, other cosmetic genital issues that they're having, potentially transitional care, as I mentioned, and you can really, really help people, improve their quality of life. And I think that's been, a very important part of my practice. And I just found that I really enjoyed doing that. And so a reconstructive fellowship, ended up being the right way to go. And I was fortunate enough to be able to come back to Columbia to practice that. So far, so good.
Yeah,
Tanya,
and
go ahead. Talk
and
about general
kind of
urology.
my thoughts towards general urology. Kind of much like my experience in med school, I kind of like everything in urology, quite frankly. And I kind of always envisioned myself functioning more as kind of a community doctor. There's a lot of what I consider really fun, kind of bread and butter urology stuff. You can kind of a smattering of all the different fields, although general urologists tend not to do a whole lot of peds stuff, but besides for peds, they'll tend to kind of do various procedures kind of within the various subspecialties. Sometimes for the more complex things, they'll then refer to a specialist, but kind of general urologists can do a lot of different things in a lot of different subspecialties of urology. And a lot of those things I just find really fun. Yeah, like a lot of our endoscopic procedures, working with lasers, things like that, are just kind of fun procedures. And like I said, I think kind of the notion of being able to work kind of in a community as that general urologist that can then kind of refer to specialists as needed is just something very appealing to me, kind of working with a really broad population base.
I think, yeah, just echoing all these points, urology is unique in that there's a surgical component to it where you can do a variety of different procedures, either in the office or in the operating room or endoscopically, and at the same time maintain a very special longitudinal close relationship with patients, because these are often lifelong conditions that need follow-up care. So what Dr. Joice was talking about, transitional urology, that is one of those fields that exemplifies that. That means taking somebody who has issues, pediatric urologic issues, and transitioning them into adulthood and moving them into the next phase of their life, supporting them. And that's needed for different complex bladder conditions, among other issues that urologists deal with.
Thank you for sharing. So my next question is, what does your typical day look like? And then for Dr. Schoenfeld, what does your typical day as a resident look like?
Greg, Dr. Joice, why don't you tell everybody about your day?
Yeah.
It's like you're wrapping up a very busy day.
Yeah, it depends. It depends. I'm at the phase of my career early on where, my goal is to be busy and to establish a practice and see as many patients as possible. And I'm pushing the envelope in terms of how many patients I can see in a day. But I'm fortunate that I get to go to a lot of different places. So I work here at Columbia at our, the main campus. I work at the Allen Hospital, which is in Washington Heights. I work at the Bronx VA, which is in the South Bronx. And I work up at a clinic and hospital in Tarrytown, which is in Westchester. And so depending on what day it is, I'm in any one of those different locations. I probably spend on average about 3 days in clinic full time. So that's a full day. I'll see anywhere from 20 to sometimes 40 patients, doing some procedures during that, cystoscopies, looking into the bladder, injections for erectile dysfunction. So that's usually a pretty busy day. And then the other days I will be about 1.5 days in the operating room. And that can either be 4 to 5 smaller cases that I would do back to back, more outpatient surgery, or it can be 1 to 2 larger cases. I do robotic surgery, so that's surgery assisted by the Da Vinci robotic device. I'll usually do about 2 of those in a day. We have 2 tomorrow. And so that's a day where, I come in early, we do a couple of those cases, last around all day, and then I get to go home. And then the other half day is academic time. So I do have some dedicated time to work, on research projects that we've got going on, start new research projects, work on my administrative tasks, and really just time to sit back and perform the academic side of my practice. And so that's, pretty good, but it's pretty busy 5 days a week. After that, our weekends are usually pretty off. We do take call, but urology call is not too difficult. And so we come in and have to do some cases every now and then.
Yeah, my practice is different. I do work in several of the similar practice settings that Dr. Joice works in. We both rotate through the Bronx VA, so we take care of our veterans. I find my time there very rewarding. There's a growing proportion of women veterans, and women's health is a growing need there. And my practice there really consists of women that want to see other female urologists and talk about some of their issues with, again, incontinence, blood in their urine, recurrent urinary tract infection, those type of problem sets. So that's where I spend part of my week. I also work at one of our community hospitals 2 days out of the week, seeing a similar subset of patients. I do mostly office-based procedures to treat these conditions that I spoke of. One thing that I didn't really think about when I was choosing a career is I thought most people, to be a doctor, you see patients 5 days a week, or you do surgery, 5 days a week. But remember that you don't have to lose the things that you love, and be very creative and intentional about what the things that you love, and don't let go of those things. So if you want to be in international work, if you want to assume different types of leadership, administrative leadership positions in the hospital, if you want to, as Dr. Joice was saying, carve out time to innovate and be committed to outcomes research, clinical research, that's important. And you should really think about incorporating that to your practice. For me, it's medical education. And that's a full day of my week, is just meeting with our medical students and our lovely residents. That's very rewarding for me, and that's really something that fulfills me just as much as seeing patients.
Yeah, so I'll give the resident perspective on this whole thing. It's funny, right now I'm kind of speaking to you. Some urology residencies, the 6-year urology residencies tend to have a research year. So I'm kind of living the high life of being on my research year right now, which at which point your clinical responsibilities really diminish and you really are kind of dedicated research. But I suspect that's not kind of what most of you guys are interested in hearing. So I think, urology residency, kind of wherever you go, the various places I interviewed at, it seems like there's kind of their main rotations that are very challenging. Then you can kind of have some other rotations as well. When you're really kind of in the main hospital, I think that might be the most relevant day to kind of describe. Depending on kind of where you are in your training, kind of the younger you are in your training, the earlier you tend to come in, but you probably come to the hospital anywhere between 5:30 and 6:30 in the morning. You'll round on our inpatients, and then generally you kind of spend the day operating, quite frankly. Again, kind of as you move up in the program, in any program, the surgeries that you're assisting with become increasingly complex. But very often, you will leave anywhere from kind of at the end of the surgery day, which might be kind of 5:30. Sometimes, as my attendings will attest to, surgeries can end up going really late, at which point you're there late. But there are a lot of new kind of laws in effect right now about resident duty hours, and that applies to surgery residents too. And our program is very strict about it. And I think most surgical programs are, that you're really not supposed to go beyond an 80-hour work week. So days can be really long and tiring, but it all balances out, where most programs are being really diligent about making sure you're not there for too long. But yeah, kind of rounding on patients in the morning and then kind of operating the rest of the day is what most of my day looks like.
Thank you. So my next question is, Dr. Badalato, can you speak a little bit on what a day in private practice may look like?
Yes, I am not in private practice. But I do have we do have some people in our department that were in private practice. It was something that I thought about when I was graduating from residency. a job that I did consider. I think it's similar in the types of conditions that you treat, patients that you treat, the different procedures that you could perform, but there's less a focus on some of the academic things that we spoke about of research and education that's not as much embedded in that environment. But the scope of the practice is very similar, potentially for some of the things that Dr. Joice was referencing that he does in terms of reconstruction. That's probably more of a a tertiary care or an academic type of environment that someone would treat many of those some more complex conditions. But being a first line provider to see and evaluate somebody with blood in their urine, someone that has a kidney stone, somebody that wants a circumcision, somebody who's having trouble urinating, they feel like their prostate's enlarged, someone who has an elevated prostate specific antigen or prostate screening test, someone who's had a lot of urinary tract infections, someone who has issues with erections, erectile dysfunction. These are all types of problem sets that somebody in private practice would likely see and manage. I don't know, Dr. Joice, if you want to add anything to that, or Donnie, based on Dr. Schoenfeld, anything based on your early career?
Yeah, I mean, I think, knowing some colleagues in private practice and having interviewed at some private practices, I think it's generally speaking very similar, like Dr. Badalato said, without that academic time. So, I technically have 20% of my time that's dedicated to education and research, and that's in working with med students, working with residents, going to conferences. It's not that people in private practice don't do those things, but they're not the focus. Their focus is on clinical care. So the other 80% of my time in clinic in the operating room will be very similar to what they do. I will say there are now some, especially in urology, some very, very large private practices that start acting a little bit like academic institutions. Privatemics is what we've been calling them, but basically institutions that some have fellowships, some have rotations from residents, some have research arms. So that dichotomy is blurring a little bit. So I think it's generally similar. The education and teaching and research is really the main difference that I see.
Yeah, I don't really have, honestly, much to add. I've been immersed in the academic medical urology field at this point, but so I would defer to kind of other people on that one.
Okay, so my next question is, are you involved in any research? And if so, what is the area of focus for your current studies?
Yeah, we're involved in a lot of research. Donnie and Joe, amongst others, are part of the team. And really, again, most people will do research in their specialties. So my research, men's health, reconstruction, we're doing a lot of research into men's psychological kind of understanding of ED, what promotes people to go get treatment for sexual dysfunction. I have a colleague who's actually doing some research that I'm involved in and looking at the partner's perspective to sexual dysfunction after prostate cancer treatment. We're doing some database style kind of healthcare outcomes research. We also have some microbiome basic science research. So we're doing a lot of different projects, mostly within the sexual health reconstructive field. One of the best things about being at a place like Columbia or just being involved with it, as I've told, Donnie and Joe, is that it really takes a team. And as much as someone can come in with a little bit of excitement and, ideas and, ability to learn and work, you can start a project. I mean, it really is that easy, and so working with Joe, we had some ideas, he came up with some ideas, and we just, boom, the project is going. And, that's what I really liked about urology and academics, is that you can start a project at any time. You just have to find the right group and right people. So we're involved with a lot, and that's really just what I do. You know, the whole department is doing many, many more projects, you know, all around.
Yeah, I think there's a lot of opportunity for research. I'm involved with some research at the VA looking at different types of neurogenic bladder and early physiologic markers for something called autonomic dysreflexia, which is a response that some people can get to bladder filling. And again, so the point is that there's a lot of opportunities for research. Also involved in a lot of medical education research. I see there's a question in the chat asking about grades and things of that nature. These are questions that interest me. And this is not a typical urologist interest, but I am interested in what brings people to the field of urology. Is it mentorship? Is it awareness of the field? Is it the content of what they're learning? And how are people being evaluated? What is the application and recruitment process like? So these are things that I'm involved in an academic level, looking at some of these things, some of the recruitment patterns in our field. And I'm actually partnering with Dr. Schoenfeld on some of these projects. So it's exciting because while you don't think of it as clinical research, it's important research as we think about the important aspect of diversifying our field and what is important in making people urologists and what are barriers to that. So that's something that really intrigues me.
Yeah, and just echoing kind of what Dr. Joice and Dr. Badalato said, as someone that's interested in general urology, I'm actually kind of on, this is my research here now, so these are actually kind of two of my main research mentors who happen to be on this call with me right now. So like Dr. Badalato was saying, kind of interest in medical education and kind of pathways to urology, something that interests me. Working with Dr. Joice on some of this gut microbiome stuff in men's health and sexual dysfunction. I have some projects with some of our pediatric attendings looking at how kind of pediatric patients with kidney stones are being treated compared to some of our adult patients. And then kind of really what might seem like less kind of directly medical is that I'm actually doing some projects related to prostate cancer litigation. So I'm actually looking at legal databases at the moment, which is very complicated, I must say. The legalese is much more complicated in some ways than a lot of our medical terminology. But yeah, like I think like Dr. Badalato and Dr. Joice were saying, kind of the options for research are very varied, and kind of depending on your interest, you can really get involved in really anything.
Great. I noticed that there was a question in the chat that's been alluded to. Abdallah, I'm going to unmute you. You can ask your question. Does that work? You may not be able to unmute right now. But the question was about if you're looking at residencies in urology, looking to match, and now with step one being pass fail going forward, what type of research or experiences should a student look to do before entering the match? And, you know, particularly for urology, what are some things to know about the urology match? Because it is an early match, it's unique. What are your perspectives on students who are thinking about applying to urology?
Yes, so part of the challenge is that urology is an early match. So that means that the results are announced in February, and people start planning for a career in urology as early as the summer before that. So the timeline is pushed up a little bit. And so I usually advise students, if you're considering a career in urology, it's good to plan for that early, because it's easier to kind of withdraw if you decide that it's not for you than to jump in late in the game. The question asks about things that are important in the application process. We value research insofar as it shows that you're curious about something and that you can ask a question and find a meaningful way to evaluate that and answer it. It also is a great opportunity to establish mentorship. But there are other things that we look at, not just research, but commitment to something. There are some people that have not done research, but they've been involved in very meaningful community service. They've had significant work experience or life experience, potentially with another career. This is very important, in my opinion. It's just as important, sometimes more important than the research. But the research is important insofar as that it gives you a mentor, someone that can help you, guide you through and support you through the application process, and again expresses your curiosity towards the field. You don't need to have, first author publication. It's nice to have, just to put down that you have some research experience, and maybe you presented a poster or you're working on an abstract or something like that. The other thing that's very important is your performance during medical school. You want to make sure everybody has got a good solid foundation in clinical medicine. And then also it's very important to think about visiting sub-internships. This is very important in urology. Usually students do up to 2 visiting rotations. If they have a home institution, they do up to 2 visiting rotations. If they don't have a home institution, maybe more, up to 3. And it's a great way for you to kind of rotate, almost like a job interview, showcase your skills at a place where you're interested in going to for residency. And some studies have shown that, your chances of matching at a place is higher at a place where you've done a visiting rotation at. So this is a very important part of a process. And the mentorship is tied to that, because navigating where to do your rotations, when to do your rotations, and things of that nature is very important.
Yeah, I think, just one other thing, kind of like Dr. Badalato mentioned, it's nice to see something on the application that shows, some degree of follow through, and not necessarily completion, but something that someone is really interested in. So when I see some applications, med students will have like 20 projects with 10 different mentors, and I know that they're not really working on all those projects. It's not possible. And when we were at another one of these kind of sessions, actually it was the chair of ENT here who brought up, that they look more for, what's the project that you're working on? Like, what's your academic passion? What are you doing? And for many, that's research. So if it's research, whether it's in urology or not, like, do you have a project that you're working on, you're working towards completion, you've presented, and that you can talk about, with some excitement and some knowledge, or maybe it is, working in the clinic. There's been plenty of applicants who may not have the strongest research background, but they're the, medical student manager of the free clinic, and that's their passion. And when you talk to them in the interviews, they can tell you about the interesting cases they've seen, how they set up something that, excites you about that aspect of medicine. I think is good to show on the application.
And as someone who kind of just more recently kind of went through the whole interview process, again, I wasn't privy to any of the conversations about whether or not people were going to take me after I interviewed. So take everything I'm going to say with a grain of salt here. But every kind of interview that I had, the main focus of a lot of my interviews were actually about really non-medical things in my application. So a lot of it was about like a hobby of mine, or some volunteer work that I did that I was really passionate about and wrote about, and people cared about it. It wasn't kind of like lip work that they were just like, oh yeah, check a box that they're do some volunteer work. I spent a lot of time in med school working in prisons, doing kind of men's health stuff in prisons. And I would say that that was kind of the dominant thing that I ended up speaking about in most of my interviews for residency even. So even kind of in the non-directly medical academic realm, having hobbies and things that you care about and can talk about passionately, and that you demonstrate that you take seriously and have like kind of pursued some sort of leadership role in, at least in my experience, seemed to be really meaningful when I was interviewing at a lot of different places.
I see Giovanni has a hand up. Do you want to ask a question? Hold on, let me
Yes, thank you. Hi, everybody. I'm Giovanni. I'm calling from New York, and thank you for your time. I was just curious, where do you see the future of urology heading? I know Dr. Joyce mentioned using the Da Vinci robotic surgical system. Will we be seeing more of this in the future, along with laparoscopy surgery? And another question would be like, what are some areas of the field that you think would have a big room for improvement?
Yeah, that's a great question. I think, all the things you said are accurate in terms of where the field's going to go. Surgically, at this point, to be honest, the Da Vinci robot is a little bit old in terms of having come out a few years ago, and it's actually no longer on patent. But urology by far was one of the earliest adopters and still one of the highest utilizers of the robotic device. It's now gotten to the point where people like Donnie, are learning as much robotic surgery during residency. Same thing with me, as we did open surgery, which creates some issues, but I mean, there's that balance. They're always innovating on their robot, so kind of new different techniques are coming out with that. I think in terms of where the field's going surgically, we're getting a lot better with advanced imaging. And so they're starting to roll out ways where you can, particularly in oncology, specifically target small areas of cancer with a combination of imaging modalities and medication. So PET scans, MRIs, that degree of advancement in terms of treating, particularly oncology patients, is really being pushed forward at a rapid pace. In terms of where there's need for additional research, I would harp on my own specialty in benign and reconstructive urology, men's health, female urology, really all of the benign fields, I would say, are lagging behind oncology in terms of their research. It was another reason why I went into it, because there's so much to be done. Some of the projects that Donnie and I are working on, it's not rocket science, but it's the first time anyone's really looked at some of these things, just because there hasn't been a lot of focus. There hasn't been a lot of money in benign urology. The Columbia, amongst other institutions, actually has one of these very large NIH grants, which is specifically focused on benign urology, because there really has been a lack of research there. I have, again, a colleague at another institution who is applying for NIH grants, which are focused on sexual health and the partner's experience with erectile dysfunction after prostate cancer treatment. So I think people are starting to recognize that we need more research in these other quality of life type, fields. Keep going with the cancer research. That's going great. But I think there's a lot of room for improvement in those other non-oncology urology specialties.
So, excuse me, I have a question. I was just wondering, Dr. Joyce, you said that the residency is 6 years. So how do you balance your family life with, 6 years of residency? And were you married when you began your residency? Was that a decision that you made beforehand? Just curious about that.
Yeah. So it's 5 or 6 years. There are some 5-year programs and some 6-year programs. I think urology is really a good specialty that allows a lot of work-life balance. I mean, the residency is, intensive, as all residencies are, but it never supersedes, your family life or your personal life. I'm not sure about Gina, but I think all of us have had children during residency. I know for a fact Donnie and I have, and I got married during residency. I had a kid during residency, and as much as I wanted to plan it around my wonderful research year, he came along during my chief year, right in the middle of it. And it was okay. Colleagues covered for us, everybody understood. We took time off. I got to spend plenty of time with him. And so it's a field that I think is busy, but allows there to be still a focus on, personal life, family life. And again, particularly nowadays in medicine, medicine or work should never supersede family. That's always kind of number one. I don't know. Yeah, go ahead.
Yeah, just to reiterate what Dr. Joyce said there. Yeah, so I had my son, my wife had our son at the beginning of my third year of residency, which is not the busiest, but it's also kind of not the most relaxing year of residency either. I think what's nice is that, I mean, I could speak from my own institution experience. I actually got real paternity leave. I got 6 weeks off to just kind of spend with my son, which was incredible. That is kind of an increasingly common thing. There's kind of discussions within the ACGME about kind of mandating family leave. I don't know where those conversations are yet, but it's certainly something that's becoming increasingly common. And culturally, I think kind of something Dr. Joyce was alluding to, urology as a field. All my colleagues are really supportive. If, I asked if I had some family thing come up and I asked someone to cover a call, it was kind of like a no questions thing. And I think kind of just culturally, the field of urology tends to attract people who are supportive of one another, appreciate that life exists outside of residency. And it's not impossible to kind of strike that work-life balance in a meaningful way.
I agree with everything. Very supportive environment, very supportive culture. There are 20% of practicing urologists today are women, but there are many women that are actually in residency right now. So that number is growing. We really really emphasize that family planning is a part of any career. Nobody really comes into residency knowing when or if they'll get married or when or if they'll have kids. I certainly didn't. It kind of just every stage of my life kind of unfolded, but I was very fortunate to have a supportive department, working environment, colleagues. And I had 2 children, one of which was towards the end of my residency in fellowship. And then my second was in practice. I will say that I work a lot with our residents. Half of our residents here at Columbia are women. And we actually did a study looking at, concerns about family planning when you're looking at some of these longer specialties with 5 to 6 years of training. And one unique thing here at Columbia is that we do offer for certain trainees that are interested egg freezing, which is a great option to consider if that's one of your concerns and you're not sure about, again, the progression in your life and you want to think about these things. This is an option. And I think that this is part of more of a national movement and recognition of the fact that we want to support women in various careers and various training paths. This is a benefit that Columbia offers and that we anticipate that many other residency programs may offer as part of their benefits package.
I just wanted to pause for a second. If anyone else has a question, please feel free to either put it in the chat or raise your hands.
Well, I have another question if nobody else is going to ask a question. You make Columbia sound fantastic. Are the other programs around the country as culturally sensitive, just in general? I mean, is the culture of, not necessarily culturally sensitive, but is that the culture of urology as a whole, or is that the culture of your particular program? So that's my first question. And my second question is, you had mentioned mentorship quite a bit. So how do people go about getting mentors, that people who may not be in a program that has in a medical school that has a robust urology program?
In terms of the culture question, I mean, yeah, I think the culture here at Columbia is fantastic. I think a lot of that starts at the top with our chairman. But I do believe overall urology as a culture in general is just very understanding and welcoming, understanding of work-life balance. there's a perception that, urologists are the quote unquote nice surgeons, which, I think is a little bit oversimplification, but, we do have a sense of, I think, collegiality that maybe not every field has quite as much as. I mean, it's a small field, in the sense that, you go to meetings and you kind of know everybody. I still see people that I interviewed with, and we see each other at meetings. And so people are generally speaking looking out for each other. I think any program you're going to go to can have some people that maybe don't fit into that culture. But in general, I think across the board, the culture at most institutions that I've worked at have been that way. And as Donnie had mentioned, I mean, some of this is actually legally binding, in terms of how people are treated, work hours, and such as that. And then the other question. Mentorship, yes.
Mentorship.
Yeah. So Gina can probably speak a little bit better about that, but I think the key thing is just getting in the door. And if you don't have a home program, finding somewhere, coming to see us, talking to, those of us that are on the call today, and just starting the conversation. For me, Gina happened to be one of the, resident kind of teachers in this class that we had on, foundations of clinical medicine. And I had expressed a little interest in urology. I talked to her and she sent me to Dr. McKieran, and then that was it. He was my mentor for, a decade after that. And so sometimes it takes just getting started, finding the right people. It doesn't always go that way. You may find a mentor that may not gel with right away. Don't give up. Just find someone new, start different conversations.
Yeah, I think urology is unique in that you don't necessarily need to have a home program or a mentor at your home program to find them. To find somebody. There are a lot of national organizations that you can consider joining. The American Urologic Association, if you Google American Urologic Association or AUA, has a curriculum for medical students, and you can actually join the AUA for free as a medical student and get information on webinars, conferences, things of that nature. There's another great organization called Urology Unbound, and I'll post the link in the chat. This is an organization specifically to recruit people who are underrepresented in medicine into the field of urology and pair you with a mentor nationally. And I am involved in this organization as well. I'm a faculty mentor, and I can speak, very highly of this program. I'm also part of Society of Women in Urology. This is another organization that welcomes medical student participation and free, opportunities to be paired with a mentor. So think about these things: the American Urologic Association, this Urology Unbound, and I always on the AUA website, there are different types of research opportunities that might be available in a certain section of the American Urologic Association. So I think that website is a great resource if you're looking for research, if you're looking for mentorship, or even just looking to learn a little bit more about urology. I'll put that also in the chat right now.
Great. And while you do that, I see Nancy has her hand raised.
Yes, thank you. My name is Nancy. I am actually a UCLA medical student that snuck in to this meeting. I am currently, so I've finished 3 years of medical school, and I'm currently on leave of absence, doing a master's in public health and health policy at Harvard. And my question, something that I've been thinking a lot about through my 1 month stint so far in the program, is what I want my career to look like. I know we talked a lot about what private practice looks like and what academia looks like. And I think something that I have struggled to find is really mentors or careers to emulate of someone in urology who's also very involved in policy work or, in advocacy and those sorts of things. So I was wondering, in your experience, what that looks like, what sort of, I guess if there are places that are more conducive to that, or just, thoughts about engaging in policy and advocacy as a urologist. And then a sort of second part to my question related to that, I'm interested in going into urology for gender affirming care. And I know Dr. Joice mentioned that's something that you do. So I was wondering what, I guess, the state of delivering gender affirming care looks like sort of across the board. Yeah, in your opinion.
Yeah, I think, in terms of policy, there's plenty of opportunities. So there's actually, the AUA has a policy meeting every year. And I went to that once, and we went down, and you go to Capitol Hill and you split up by states, and you actually go to the Congress people and the senators, and, go with whatever the AUA's policy, things are for that day. So that's an opportunity. There's a whole policy arm of the AUA that has different people in it. There's a residency policy fellowship. I forget what it's called, but when I was training, one of the fellows was doing that. And so he was in Baltimore for his clinical training, but then he would go down to DC and worked with, I forget, one of the Congress people to kind of work on policy. So there's definitely plenty of opportunities. Again, I think it's just about finding the right, mentors. And we can definitely help you find someone, that would be good at that. In terms of gender affirming care, I mean, it's one of the, kind of biggest waves in healthcare and in urology in general. So it traditionally has been, done by people with reconstructive training like myself. Now they actually have fellowships, a couple in New York, several around the country that are focused not exclusively, but primarily on gender affirming care. We have a resident here who is going to a fellowship to have that be a large part of her practice, and planning to do that as, the primary part of her career. Believe it or not, we're actually starting a transgender center at the VA, which is pretty forward thinking. That's had to do with some, recent policy changes. And so I think it's only going forward from here. I think it's only going forward from here. It really is a multidisciplinary team. The urologists kind of help out in a major way, but it involves plastic surgeons, mental health specialists, gynecologists, primary care. And, I think is really going forward. And it's another kind of quality of life, quote unquote, thing, but really some way that you can change people's lives. And I think it's a great reason to get interested in urology and learn more about it. And I think Gina's linking some stuff in the chat about the policy.
I think Donnie should comment on this because he knows a lot about the health policy component of urology, and actually has applied for some of these this fellowship here.
Yeah, hey, I kind of like you. Actually, our stories have some similarities. I was also really interested. I had mentioned earlier that I had majored in political science. I also in med school actually was very kind of intimately involved in the transgender health program at Montefiore, which is where I went to med school, Einstein Montefiore. Yeah, I think like Dr. Badalato and Dr. Joice mentioned, there is kind of an abundance of opportunity. It does take time to kind of apply to these things, but kind of once you apply, there's an enormous amount of support. A lot of these are funded. Most institutions provide support for you as well. And kind of, it's true that the AUA kind of dictates a lot of kind of what the policy initiatives are, but kind of in terms of kind of the future of urology and, that's you guys, people like you who are interested in urology and you choosing what become areas of policy focus, kind of that's why having a diverse field of urologists is so important, because if you guys pursue urology, you'll be the ones ultimately kind of dictating policy. And so I'm interested in potentially policy related to coverage of gender affirming care, things like that. It exists out there. A lot of opportunities to pursue that do exist, and if you're interested, it's really easy to get involved.
I'll say from the staff side perspective, since I work for professional associations, I would encourage every single person in medicine to get involved in policy work. I mean, there is nothing more effective than somebody who is actually doing the work, talking to the people who are making the policy, and being one of those people. So I strongly recommend you get involved in your professional association, AMSNY, if you are a New Yorker, any group you can get involved with that speaks to you and what you're passionate about. Highly recommend. All right. I saw one other question in the chat. I know we are running very, very up against time. There's a question about traveling abroad and doing work as a urologist, pro bono work, perhaps medical mission work. I don't know if any of the three of the panelists have done these trips or are interested in it or know about opportunities.
Go ahead, Greg.
Oh, yeah, I was just gonna say, I mean, there generally are a lot of opportunities. I know in my residency, there were some trips that people were making to the Caribbean. In my fellowship, actually, my fellowship director for many years has gone to Honduras every year to do, a large volume of reconstructive surgery and urethroplasties, really the complex surgery that the urologists down there aren't trained to do. That got halted because of COVID, but I'm sure it's, coming back, and it's going to be back in full force because a lot of those patients haven't gotten care over the last couple of years. And so there definitely are plenty of opportunities, you just have to kind of find them.
Yeah, I agree. I mean, unfortunately, a lot of this was on hold during COVID. It's getting reactivated now. We've had past attendings in our department work with this organization, IVU Med, to do international work. But some have worked independently with other private organizations, medical missions to go abroad. I think Dr. Joyce's expertise in reconstructive urology is really an asset for international work. This is something you can also embed into your training as a resident, depending on the structure of your residency program, to do some medical missions abroad with enough advanced planning. There are scholarships, again, through this IVU Med for residents to pair with a faculty member that maybe not necessarily be from your institution in order to do some of this work.
All right. So as to be respectful of everybody's time, I think we're going to wrap it up now. Thank you so much, Dr. Joice, Dr. Badalato, Dr. Schoenfeld, for joining us tonight. It's been excellent, and we will follow up with everyone here. The recording will be available. Please share if you know someone who wasn't able to join tonight. And we will include the links that also about the resources Dr. Badalato was sharing in the chat. We'll try to include those in our follow-up. Thank you so much. Night.